Welcome to the training module of vaginal discharge. I am Dr. Rupinder and I will be guiding you through this topic. For this topic, we will go through a little bit on normal vaginal discharge. Then we will go through the common causes of abnormal vaginal discharge, such as bacterial vaginosis, trichomoniasis, vulvovaginal candidiasis, and then we will move on to syndromic approach to vaginal discharge and one case discussion. So let's begin. Vulvovaginal symptoms is one of the commonest reasons for women's visit. Most of the time, it's caused by bacteria, fungi, or parasites. Symptoms include abnormal vaginal discharge, vulval irritation, or itching. About 90% of this caused by infection, mainly bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. Can be caused by infections of vagina or cervix, inflammation, or changes in the normal vaginal flora. These three diagnoses should be excluded before considering less common causes like atrophic vaginitis, cervicitis, foreign body, irritants, and systemic medical disorder. The most commonest cause of vaginal discharge is physiologic discharge or caused by hormones. So normal physiological discharge changes with menstrual cycle. The character of the discharge tend to be clearer with a stretchable consistency around ovulation, then may be thicker or slightly yellow during the luteal phase. Normal healthy discharge should not be associated with symptoms such as itching, redness, and swelling, and does not have a strong odor. Vaginal discharge can increase during higher estrogen state such as ovulation, the luteal phase, puberty, and pregnancy, and with estrogen-based therapies such as combined hormonal contraception and hormone replacement therapies. Normal vaginal discharge is found in 10% of those who present with vaginal discharge. What is normal vaginal discharge? A normal vaginal discharge will have clear, milky, or off-white color. It's non-malodorous. The pH is 3.5 to 4.5. It is about 1 to 4 ml per 24 hours. It's composed of desquamated vaginal epithelial cell, mucus produced by glands of cervix, transudate from the vaginal walls and secretions from the gland, facultative microorganisms. The normal vaginal ecosystem is composed mainly of lactobacilli. Lactobacilli is the most common bacteria in the vagina of a healthy woman and plays a vital role in maintaining the vaginal health. So it is found in 96% of women. The concentration is about 10 to power 5 to 10 to power 8 per mil. Lactobacilli have been generally considered the gatekeepers of vaginal ecosystem. Lactobacilli have been shown to inhibit the in vitro growth of pathogenic microorganisms such as Bacteroides fragilis, E. coli, Gardnerella vaginalis, Mobiluncus species, Neisseria gonorrhea, Streptococcus anaerobius, Prevotella beavia, and Staphylococcus aureus. It works mainly through the action of lactic acid. Lactobacilli helps to keep the vagina pH low, which is about 3.8 to 4.2. Estrogen increases vaginal epithelial glycogen. Glycogen is metabolized by lactobacilli into lactic acid. Lactobacilli also help to prevent long-term colonization of vagina by adhering to vaginal epithelial cells. This usually reduces pathogens from infecting to the vaginal epithelium. Other antagonistic mechanisms include hydrogen peroxide, a broad-spectrum antimicrobial, and bacteriocins, which is an antimicrobial peptide production. This diagram illustrates a healthy vagina and a non-healthy vagina. A healthy vagina microbiome is dominated by lactobacillus, which produces antimicrobial compounds that defend against pathogens. Now, vaginal dysbiosis will occur when the balance of vaginal microbiome is disrupted. How can a vaginal microbiome be disrupted? There are a number of causes such as excessive vaginal douching, usage of antibiotics, and smoking. Now let's talk about abnormal vaginal discharge. When there is change in amount, change in consistency, change in color, change in smell, it is an abnormal vaginal discharge. It may be associated with pruritus, burning, irritation, erythema, dyspareunia, spotting, dysuria, abdominal pain, and fever. The amount can be copious, the consistency, the texture can be more thick or curdy, it can be foul smelling, which indicate infection, the color can be yellow, green, or gray discharge, which can indicate a bacterial infection or STI. Alright, let's move on to bacterial vaginosis. Bacterial vaginosis is a polymicrobial clinical syndrome resulting from replacement of the normal hydrogen peroxide producing lactobacillus species in the vagina with high concentrations of anaerobic bacteria, for example, your Prevotula species and Mobiluncus species, Gardnerella vaginalis, and Mycoplasma hominis. It causes an imbalance in the vagina pH and ecology. It is not an STI, but it's frequently detected during STI screening. Bacterial vaginosis is the commonest cause of abnormal discharge in women of childbearing age. What are the risk factors for bacterial vaginosis? They are vaginal douching, smoking, presence of STI, receptive cunnilingus, excessive vaginal washing or frequent bath, recent change in sex partner. Clinical features. The symptoms include offensive fishy smelling vaginal discharge not associated with soreness, itching or irritation. Many women, approximately 50%, are asymptomatic. The signs include thin, white, homogeneous discharge coating the walls of vagina and vestibule. BV is not usually associated with signs of inflammation. Let's move on to the diagnosis of bacterial vaginosis. So we can diagnose bacterial vaginosis using microscopy by Hay-Eisen criteria with a gram-stained vaginal smear or EMSL criteria. Okay, let's talk about Hay-Eisen criteria. In Hay-Eisen criteria, we need to examine a gram-stained vaginal smear under a microscope to grade the appearance of vaginal flora. Grade 0, there is no bacteria present. Grade 1 is normal, where Lactobacillus morphotypes predominate. Grade 2 is intermediate, where there is mixed flora with some lactobacilli, but Gardnerella or Mobiluncus morphotypes are also present. Grade 3 is bacterial vaginosis, where Gardnerella or Mobiluncus predominate and there is few or absent lactobacilli. Grade 4 is gram-positive cocci predominate. Okay, you can see the diagram. Grade 1, there is a lot of lactobacilli present. And in grade 2, there is lactobacilli present, but there is also other organism present. And in grade 3, there is few or absent lactobacilli. Another way to diagnose BV is using the EMSL criteria, where at least 3 out of 4 criteria are present for diagnosis of BV. One is thin white homogeneous discharge, clue cells on microscopy off bed mount, pH of vaginal fluid more than 4.5, and release of fishy odor on adding 10% KOH. This is called Whiff's test, where we add 10% KOH to get intense putrid fishy odor. And to observe clue cells, we need to use 1 drop of vaginal fluid mixed with a drop of normal saline and is observed under microscope. So how do we treat bacterial vaginosis? The general advice is to avoid vaginal douching, use of shower gels and use of antiseptic agents or shampoo in the bath. Treatment is indicated for symptomatic women, women undergoing gynecological procedures, and pregnant women. So the preferred treatment is metronidazole 400 mg per oral 12 hourly for 5 to 7 days or metronidazole 2 gram per oral stat. The alternative treatment regime is clindamycin 300 mg per oral 12 hourly for 7 days. Please note, single high dose of metronidazole is associated with gastrointestinal side effects. Right? So routine screening and treatment of male partners are not indicated. A test of cure is not required if symptoms resolve. If treatment is prescribed in pregnancy to reduce the risk of preterm birth, a repeat test should be made after 1 month and further treatment is offered if there is evidence of recurrence of PE. Let's move on to the second topic, which is trichomoniasis. Trichomonas vaginalis is a flagellated protozoan. In women, it's found in the vagina, urethra, and paraurethral glands. Urethral infection is present in 90% of infected women, although the urethra is the sole site of infection in less than 5% of the cases. In men, infection is usually of the urethra, although trichomonads have been isolated from subpreputial sac and lesions of the penis. Trichomonas vaginalis is almost exclusively sexually transmitted. Due to site specificity, an infection can only follow intravaginal or intraurethral inoculation of the organism. It has been isolated in 14 to 60% of male partners of infected females and in 67 to 100% of female partners of infected males. In females, 10 to 50% of infections are asymptomatic. The incubation period for TB is 4 days to 4 weeks. Let's talk about the symptoms. In women, 10 to 50% are asymptomatic. Commonest symptoms are vaginal discharge, vulval itching, dysuria or offensive odor, occasionally low abdominal discomfort or vulval ulceration. In men, 15 to 50% are asymptomatic and usually present as sexual partners of infected women. In symptomatic men, the commonest presentation is urethral discharge and or dysuria. Other symptoms include urethral irritation, urinary frequency, and rarely purulent urethral discharge or prostatitis. Signs in women up to 70% have vaginal discharge from thin and scanty to profuse and thick. Classical frothy yellow discharge occurs in 10 to 30%. Other signs include vulvitis, vaginitis, and 2% of patients have strawberry cervix. In men, 20 to 60% men have urethral discharge, usually have small or moderate amounts only and or dysuria. Diagnosis: swab is taken from the posterior fornix during speculum examination. Detection of motile trichomonads by light field microscopy. Vaginal discharge is collected with swab or loop mixed with a drop of saline on a glass slide and cover slip placed on top. The wet preparation should be read within 10 minutes of collection. Sensitivity is highest in women presenting with vaginal discharge, and a visualization of motile trichomonads in these women indicates the presence of infection. TB culture can be done by nucleic acid amplification test or NAT. Sensitivity of it is 95 to 100% and specificity of 92 to 100%. Diagnosis in men. For men, TB testing should be done for TB contacts and considered in those with persistent urethritis. Urethral culture or culture of first void urine will diagnose 60 to 80% of cases. Complications of TB. There is evidence that TB is associated with preterm delivery and low birth weight in pregnancy. TB infection at delivery may predispose to maternal postpartum sepsis. Screening of asymptomatic pregnant women is not recommended. Growing evidence that TB infection may enhance HIV transmission, and there may be an increased risk of TB infection in those that are HIV positive. For treatment, The preferred treatment for Trichomonas vaginalis is metronidazole 400 mg per oral 12 hourly for 7 days or metronidazole 2 grams per oral stat. There is no alternative treatment regimen for Trichomonas vaginalis. Single high dose of metronidazole is associated with gastrointestinal side effects and higher play rates, especially if partners are not treated concurrently. For contact tracing, sexual partners should be treated simultaneously. Patients should be advised to avoid sexual intercourse, including oral sex, for at least 1 week until they and their partners have completed treatment. Let's move on to the third topic, vulvovaginal candidiasis. Vulvovaginal candidiasis is an acute inflammatory dermatosis of vulva and vagina caused by mucosal invasion of commensal yeast species. 80 to 92% is caused by Candida albicans. Non-albicans species, for example, Candida glabrata, Candida tropicalis, Candida krusei, just to name a few. The clinical features, the symptoms include vulval itch, vulval soreness, vaginal discharge, thick, curdy, white, although discharge can appear normal or absent, dyspareunia and dysuria. Signs include erythema, fissuring, discharge, typically curdy but may be thin, non-offensive, edema, satellite lesions, and excoriation. Diagnosis: gram stain of vaginal discharge will appear yeast-like cells on microscopy, and 10% KOH preparation will help to identify yeast or hyphae. Culture can be used for symptomatic women with negative microscopic examination with subaround stachys agar. Treatment for uncomplicated infection, clotrimazole 500 mg as a single vaginal pessary stat is given. Alternative, fluconazole 150 to 200 mg per oral stat. For complicated infection where there is severe vaginitis symptoms, fluconazole 150 to 200 mg per oral 72 hourly for 2 or 3 doses. For recurrent infection, fluconazole 150 to 200 mg every 72 hours for 3 doses, then weekly for 6 months. Clotrimazole 500 mg vaginal pessary weekly for 6 months as an alternative. In pregnancy, clotrimazole 500 mg as a single vaginal pessary stat is given. If indicated, treat with topical therapy, as azoles are contraindicated in pregnancy. Let's talk a little bit on recurrent vulvovaginal candidiasis. 5% will develop recurrence, at least 4 documented episodes per year with at least partial resolution between episodes and positive microscopy or a moderate or heavy growth of Candida albicans on at least 2 occasions when symptomatic. Risk factors include uncontrolled diabetes mellitus, immunosuppression, hyperestrogenemia, HRT and the combined oral contraceptive pill, disturbance of vaginal flora, example after broad-spectrum antibiotics usage. Contact tracing is not required. There is no evidence to support treatment of asymptomatic male sexual partners in either episodic or recurrent candidiasis. Follow-up is unnecessary if symptoms resolve. Test of cure is unnecessary. Let's move on to MSA or modified syndromic approach to vaginal discharge. Right. So let's look at the flow chart for the syndromic approach to management of women presenting with vaginal discharge based on speculum examination. So any person with symptoms of vaginal discharge, vulval itching or burning, please take medical, sexual and assess risk for STI. Examine patient, external speculum and also by manual examination. Look for lower abdominal tenderness or cervical motion tenderness. If present, Use flowchart for lower abdominal pain. If there is no lower abdominal tenderness or cervical motion tenderness, look for cervical mucopurulent discharge. If present, do wet mount or gram stain, culture and sensitivity, or NET if available. Screen for HIV, Hep B, Hep C, and syphilis. Offer same-day treatment for gonococcal and chlamydial infection. Educate, counsel, promote condom use, and provide condom. Epidemiological treatment for partner. Notify case when laboratory confirmed. Ask patient to return in 14 days. If there is no cervical mucopurulent discharge, if there is vulvar edema or curd-like discharge or erythema present, 2 grams stain of vaginal discharge and high vaginal swab for culture and sensitivity if available. Screen for HIV, Hep B, Hep C, and syphilis. Offer same-day treatment for candidiasis and bacterial vaginosis. Ask patient to return in 14 days. If there is no edema or curd-like discharge or erythema present, consider alternative diagnosis and refer accordingly. So now, before we end, let's go through a short case together. So we have a 24-year-old lady who is single, sexually active, presents with thick whitish discharge for 1 week with some itchiness. She denies fever, pelvic pain. She has 2 sexual partners, never used condom, on OC pill, 3 episodes of similar history prior to this. So on examination, BP 11278, pulse rate 72 beats per minute, temperature 37.3, abdominal examination, no abnormality detected, normal external genitalia with few excoriations near the introitus, speculum is as shown as the diagram. So for investigation, a vaginal swab for microscopy and culture was sent. Her RBS was normal. HIV rapid test was non-reactive. UPT was negative. The vaginal swab on microscopy reveals pseudohyphae and Buddingese. So what will be her diagnosis? So she will be diagnosed with recurrent vulvovaginal candidiasis, defined as having 4 or more episodes of symptomatic candidiasis per year. For this patient, this is her 4th episode, and she also complained of curdy discharge with itchiness. So for this case, we will treat her with either fluconazole 150 mg to 200 mg every 72 hours for 3 doses, and then weekly for 6 months. Or we can use clotrimazole 500 mg vaginal pessary weekly for 6 months. Tropical therapies are recommended for pregnancies as oral therapy is contraindicated. We need to advise her to avoid local irritants such as perfume, soaps, and avoid tight-fitting synthetic clothing. No evidence to support epidemiological treatment of asymptomatic male sexual partners. That's all. Hope you have benefited from this topic and all the best for your exams. Thank you.